Hey guys, the block. Do you hear me?
Yes, we hear you.
Okay, perfect. I just wanted to make sure it's working. And just to make sure, hold on, let me see. Right now, do you see my board review part 1 thing?
No, we don't see. Oh, yes, now we do.
Okay. Perfect. I'll give everyone a few minutes. You just finished the other review, correct?
Yes.
Okay. All right. Got it. Okay, I see how that works. Let me just change the laser pointer. Give me 1 second. Click here to add laser pointer. Are you okay with me using a mouse like this, or do you want a laser pointer? I guess this is a. Okay. All right. I'll give it another few minutes and then we'll start. Just one more time, someone unmute themselves. You can hear me okay, like this level of noise, or you hear that little beeps in the background when people join? This level of sound is okay for everyone?
Yeah.
Okay, perfect. All right. Okie dokie. Okay, so do not get scared about the amount of board review PowerPoints I posted. I try to do something a little different. If you guys remember me, I did some osteology lectures for you last year. And a little bit on, discussion on some joint ligaments and joints as well. But what I've tried to do was basically the high yield objectives that Dr. K was talking about beforehand. You know how there's high yield topics that are asked on the exam. What I did was in these reviews, I kind of listed the high yield topic of discussion, and then I combined information from Dr. Dickey's ligaments packet and the osteology packet to kind of bring it all together so you have a guide. Now, it's not 100% all the bullet points, but I think I pretty much covered everything except for a couple of discussion topics. I could send you, or Dr. K could send you this, the osteology of the foot and the joints of the foot high yield topics separately. Just a list of them. There was one that was number 13 that basically just wanted to talk about clinical aspects of osteology of the foot: heel spurs, neutral triangle of the calcaneus, talar torsion, talar vascularization, status process, metatarsal stress fractures, fusion of the middle and distal phalanges of the foot toe. Now, you guys, different lecturers gave you different presentations on these various topics. I'm going to try to put a little review of it together after I look over their lecture. So that's the only one I didn't pretty much cover, and the rest is covered. Let me just make sure we're okay. Give me 1 second. So that's how we're going to do this. Let me just see. Okay. So all of these people are here. Okay, guys. So I am going to, is there a lobby? I didn't even realize there's a lobby. All right, I'm gonna start in the next minute. So what I'll try to do is go over these objectives. So what I mean by that is the high yield objectives on the exam, or high yield topics that we know that they're more likely to ask about, which is pretty much everything, but it's kind of rated. The list comes in this type of format. It's a topic, and then there's a value of 3 and change up to 4. So obviously the higher the number, the more high yield the topic, the more likely to ask on the boards, So what we will do is we will see the objective as per, boards breakdown, and then we'll discuss it. Now, there's a lot of slides here. I may not cover all, but at least you have the information, okay? So let's start. Describe the anatomical, biomechanical, meaning medial, lateral column, and surgical, forefoot, midfoot, rear foot divisions of the osteology of the foot. I mean, this is all just basically terms that the first thing you kind of learned when you started osteology of the foot, right? So, oh, by the way, I'm going to skip some slides. So even though they're terms, they are used to classify areas of the foot, and especially when you come out and practice, you're required to do a certain amount of forefoot surgery, midfoot, rear foot surgery. So these terms come up. These are easy questions to get on the boards and to easy points to obtain. So again, we have 26 bones in the foot, not including the sesamoids and accessory bones, obviously. And different people have different number of accessory bones, right? Because accessory bones are not always constant, not always present in some. For example, some people may have, sesamoids in the lesser phalangeal joints. Some may not, and some may have, an accessory bone elsewhere in the foot. So the constant sesamoids that we know that exist are the sesamoids underneath the first metatarsal phalangeal joint, the 2 of them, okay? So again, anatomical organization, 3 sections. You have your components of tarsus, metatarsus, and phalanges, okay? So starting with the tarsus. Tarsus is basically your tarsal bones. That is going to be your talus, your calcaneus, your navicular, cuboid, the cuneiforms, which are basically medial, middle, aka intermediate, lateral cuneiforms, medial, intermediate, or middle, and then lateral cuneiform, and basically the cuboid. So 7 bones arranged in 2 sets. You have your proximal row, the row closer towards the body, which is your talus, and your calcaneus, which is termed the hind foot or the rear foot, and the distal row of bones, which is of the tarsus, which include your navicular, your cuboid, and the cuneiforms. Okay, and that's basically your midfoot. So all of these guys are your tarsal bones, tarsus, but you're going to have a separate division for the rear foot, which includes the talus and the calcaneus, and then for the midfoot bones, it's going to be navicular, cuboid, cuneiforms. Why it's important? Because as a resident, you're going to have to be required to do a certain amount of rear foot surgery, which specifies to do surgery on these 2 bones. And then you're going to have to do a certain number of midfoot procedures. There's medial midfoot, lateral midfoot, which is basically all of these bones right over here. Okay. Then you have your metatarsus, which is the 5 metatarsal bones, correct? And together with the metatarsals with the phalanges, this guy right here is grouped as the forefoot. So when you're doing the forefoot surgery is basically, it's including your bunion surgery, which, work on the metatarsal bones, and then, your while osteotomies for the lesser metatarsals, your bunion surgery for the little, bunion that's formed around the 5th metatarsal head and 5th metatarsal phalangeal joint. So basically metatarsals and the phalanges together are classified as the forefoot, and that's when you're going to be required to do most of your surgeries on the forefoot. And phalanges are basically our 14 toe bones. Okay, so pretty easy. So again, forefoot, metatarsals, phalanges, midfoot, navicular, cuboid, and the cuneiforms, hindfoot, talus, and calcaneus. All right, another review. Okay. So medial longitudinal arch, lateral longitudinal arch, classically, they are board questions. It's easy, just spit back type of situation. So basically you have to, they will come in the form of the following bones are included in the medial longitudinal arch, or all the bones are components of the medial longitudinal arch except for, things like that. Let's talk about the medial longitudinal arch. So again, this is half a foot, as you can see. I mean, you have metatarsals 1, 2, and 3. We don't have the rest, just to isolate to see what are the components of the medial longitudinal arch. We have the calcaneus, the talus, the navicular, okay? We have the 3 cuneiforms, okay? And metatarsals 1, 2, and 3. So this is from one of your atlases, just to make it simple to remember what are the components of the medial longitudinal arch. Remember, the medial longitudinal arch does not include the phalangeal bends, okay? For medial longitudinal arch, it ends at the metatarsal heads, okay? Lateral longitudinal arch. The lateral longitudinal arch is basically, again, you have your calcaneus. So remember, you guys, between the lateral and medial longitudinal arch, they both share the calcaneus, okay? So the lateral longitudinal arch, you have your calcaneal bone, your cuboid, and metatarsals 4 and 5. Again, remember, it does not include phalangeal bones. So what does the medial and lateral arch have in common? What they have in common is the calcaneus, okay? Now, the transverse arch. The transverse arch is another board question. What are the components that make up the transverse arch? You have your, and think about it, it's in that midfoot region, correct? The highest peak of your foot, or for, I guess, a normal, non-collapsed, not pes planus foot, you would see the arch peaking where? It's the transverse component of the midfoot at the highest peak. So we're thinking about the medial cuneiform, intermediate, and lateral cuneiforms. At that level, we also have the cuboid over here. And also that includes all 5 metatarsal bases only, okay? Metatarsal bases. So transverse arch, the cuneiforms, cuboid, and all 5 metatarsal bases. So that's a trick question, because they could give you something like, metatarsal shafts as an answer, things like that. So they could trick you. Why bases? Because at the level of the metatarsal heads, right, that's the distally, the arched form transversely is no longer present, okay? Because the medial side of the transverse arch is elevated as part of the medial longitudinal arch, only the lateral side of the transverse arch meets the ground, okay? So that's very important to know, because medially, normal, non-pathologic foot, our medial transverse arch is relatively higher. We have that medial arch, okay? And the lateral side of the transverse arch, so the lateral side of the foot, is the one that meets the ground. Otherwise, we won't be able to walk properly. So just keep that in mind. All right, so next bullet point. Describe the formation, ligamentous support, and muscular support of the longitudinal and transverse arches of the foot. Now, that is something that should have come together as far as, when you guys discussed the different types of muscles involved and things like that. We learned about the formation of these arches. We're going to talk about ligamentous support in detail, but let's just briefly discuss it. But this is something that is asked, and in the context of when you guys review the muscles and the tendons associated with those muscles, in the summary that you should have been given, you have the summary that says, okay, this is a very strong supporter of the medial arch, this is a strong supporter of the lateral arch, and things like that, okay? Okay, so let's discuss a couple of things. Again, remember, the medial longitudinal arch is higher, and it's more important in the sense that that's the one that when it collapses, it gets us into trouble, where we develop, flat foot deformity, and everything else basically goes out of alignment, okay? Both the longitudinal arch is basically, when you think of one arch, we discussed the medial and lateral components. Everything acts as a unit with the transverse arch. I mean, they're all related. It's about spreading the weight. But again, we emphasize on the medial longitudinal arch because of the fact that that's where we get the supportive components, of our normal non-pathologic foot shape. And so we have to kind of maintain that with utilizing various ligaments, various tendons, and just the shape of it, okay? Again, we have what? What are the components of the medial longitudinal arch? We have our calcaneus, we have the talus, we have the navicular, the 3 cuneiforms, and the 3 metatarsals, okay? What's of note here? So we have our the talar head right here. The talar head basically is the keystone of the medial longitudinal arch, okay? I'm not sure if you guys had functional orthopedics yet, but, the position of the talus and the talar head will determine how high your arch is or how low your arch is, okay? That's something that you guys will have to, you'll go into detail more about it after, boards part 1 after this year, but this is something like the talar head is a very keystone component, okay? And then let's talk about our tendons. So what do we have? We have our tibialis anterior tendon right here. Oop. We have our tibialis anterior tendon right here. We have right over here, we have our tibialis posterior tendon right over here. So just logically, just look at these two tendons alone. Okay, tibialis anterior, tibialis posterior. Do you see how they kind of cradle on the medial side of the foot and ankle complex? They cradle and kind of, imagine the muscles functioning. You see, they're almost like if they contract, they pull up that medial arch component. So, by these muscles, by their tendinous attachments, basically help support the medial longitudinal arch, right? By the attachment of their tendinous components. And think about it. When you have dysfunction of, these two muscles, specifically, especially the tibialis posterior, what you're going to end up happening is that you lose that major girdle supporter of the medial longitudinal arch, And just by the way, so in order for someone who had an arch, right, for them to lose the arch with age, you've heard about it, age-related pes planus deformity. So in order for someone to lose their arch and to kind of become flat-footed, it's not that one single component fails. It's a failure of a lot of things. Okay, so usually there's going to be, loosening or some kind of injury to the posterior tibial tendon or other components. Then the ligaments become loose, and all that follows. Okay. So what about fibularis longus? We have peroneus longus, fibularis longus, right? That's on the lateral aspect of the ankle joint going into the foot, correct? So that is also a very important component because the fibularis longus, it passes plantarly from the lateral to medial aspect of the foot, right? Towards the first med base. So it helps to support the arch as well. Okay, all these components. So when you're reviewing the muscle groups, the muscles of the leg that go into the foot and their tendinous attachment, just make a note. The main functions of these muscles, whether they supinate, whether they pronate, the foot, dorsiflex, plantarflex, but also there should have been a mention of what their function is as far as the arch, okay? And remember, the lateral longitudinal arch is flatter than the medial arch and rests on the ground during standing because we need that. Otherwise, if we are arched on both sides of the foot, we'd be in trouble. That's a really severe pes cavus foot deformity if there is arches on both sides of the foot, and that's a pathologic type of situation. Okay. All right. Transverse arch. So the transverse arch, what are the tendons to discuss? Again, we have the peroneus longus or fibularis longus and tibialis posterior. Why are they important? Because the peroneus longus, it travels from the lateral aspect of the foot and goes from lateral to medial. So when it fires or acts, it almost creates, that arched component of the foot. So it's very important. Again, along with tibialis posterior, which is a main supporter of the not only the medial longitudinal arch, but also the transverse arch, and keeping that curvature going if it fires and acts properly. And this is, I think, from Moore's, so basically showing different types of tendons that play a role and function in the different arches and how they, and at what point they act in the foot to kind of stabilize the foot. It's all about logic and stabilization of the components that insert into the foot. Just remember that everything is there to kind of stabilize the foot. And that's when things are not working properly. That's when we have our issues. So you guys could read about it. This is basically, this is from Moore's, I believe. They described about passive components and dynamic support of the arches. You could just go into that, different types of ligaments that are involved in supporting the medial longitudinal arch, lateral longitudinal arch, and the transverse arch. That could be just a read, so you could take a look at that. All right, so let's go over the osteology quick. So high yield thing is describing osseous structure of the talus. They do like to ask questions about the talus. One thing to note is please review your vascularization of the talus. Vascularity, it's always a question or two that pops up, and the presentation of the question is usually in the form of like, hey guys, motor vehicle injury occurred, and imaging showed that the talar neck has a fracture along so-and-so, and they will discuss risks about avascular necrosis, things like that. And then they will ask, well, if the fracture is at this level, what arterial flow was interrupted or something like that. Or they could ask a direct question. This part of the talus is, the blood flows provided by the following, or all of these blood vessels provide vascularity into the talus except for the following. So questions like that. All right. So talus, second largest bone in the foot. The first largest is obviously the calcaneus underneath it. Is involved in different types of joints. We have the ankle joints of talar joint, and then our talocalcaneonavicular joint that we'll discuss in detail. Remember, no muscle or tendon attachments directly to the talus, okay? There are ligaments that do attach to the talus, but no muscular or tendinous attachments, only ligaments, okay? And the other thing to remember is that 3/5 of its surface is covered by articular cartilage, which means that whenever something is covered by articular cartilage, there's no direct blood supply there because blood vessels do not penetrate an area that's covered by cartilage. So there's only limited portals of entry that the talus receives as far as blood supply, and that's what makes talus the bone that when it's injured, it's very difficult to heal. So it's just for comparison, if you compare fracture of the talus and compare fracture of the calcaneus, which is very often shattered in a classic fall from a ladder type of situation, that'll be the board question. The guy was putting up Christmas lights, fell, straight heeled down from a ladder, and shattered the calcaneus. You can have a shattered calcaneus, which will heal relatively nicely, obviously if the pieces are put back together, just because of the vasculature. There's a lot of blood supply to the bone, versus the talus, which is snug between so many different joints, has so much articular cartilage that's basically, the blood supply where it can enter into the talus is very limited. So this way, this is more of a danger bone. And once it has a fracture, we have a high risk of avascular necrosis where it doesn't heal, okay? That's a board question. Remember, look into the vasculature, the blood vessels that provide the blood flow into the talus, and, this cartilage surface area coverage, that's 3/5, because that's a type of a board question. Also, why do they not concentrate on finding out vasculature of other bones like calcaneus? Because there's so much of it that could go in everywhere. This is a bone that's more vulnerable, so they tend to like asking about vasculature of the bone of this one. Okay. So the head, all right? So basically, the head of the talus is directed where? It's directed medially and inferiorly down in, I guess, normal non-pathologic position, neutral position, I would say, when you x-ray someone. And the distal surface is basically very smooth and convex. And the long axis of this oval is directed, again, medially and inferiorly from the horizontal. That's how, when you x-ray someone's foot in a neutral position, like when they're just, you know, perfectly straight, standing, or putting their foot against the plate, the talus should be in that position relative to the calcaneus and then the navicular, and the rest, you know, and the rest of the bones. All right, so the oval fits into the concave facet of the navicular bone. We know that. It forms a condyloid type of joint. They do ask about joints on the boards exam, so you have to know the different types of forms of joints that are formed in, you know, the foot joints and how they function, how they move. What's important to know about the talar head? So if you look at the talar head, so talar head right over here, obviously, right? And talar head here, and all of these areas right here. So the talar head, you know, there's a superior aspect of it, and there's also inferior aspect of the talar head. And basically, when you look at the talar head as a whole entity, it has a couple of different facets, which are very important facets to know about. Remember, and number one rule, when we talk about the talus and the calcaneus, do you remember the names of the facets are switched? So if it's so when we discuss facets that occur between the talus and the calcaneus, the facets on the talus for the calcaneus, on the talus, they're called calcaneal facets on the talus. On the calcaneus, they're called talar facets. So remember, it's kind of switched over. So don't forget that. Okay, so we basically have the anterior calcaneal facet, the middle calcaneal facet, and the on the head over there. Okay, and then we'll talk about the rest of the talus when we'll talk about the posterior calcaneal facet. So the middle calcaneal facet is the most posterior of the facets of the head of the talus. And what's important about the middle calcaneal facet, okay, so the middle calcaneal facet, which is right over here. So remember, the anterior calcaneal facet, the middle calcaneal facet, they're separated from the posterior calcaneal facet by what? This is posterior calcaneal facet. It's not on the head, right? It's on the body of the talus. So they're separated by the sulcus, okay? So that's going to become important when we talk about functional joints and anatomic joints. So what's the thing to remember anatomically wise is that when you talk about the middle calcaneal facet, which is this guy right here, number 11, right? The middle calcaneal facet, it rests on the sustentaculum tali of the calcaneus, okay? So that's your, you know, that's another board question that can be asked. They just like, you know, for you guys to be aware of the orientation, what aligns with what, okay? And we'll discuss in detail about the spring ligament, the plantar calcaneal navicular ligament, which basically the location of it is going to be just anterior and medial. It's just medial and slightly in the front to the anterior calcaneal facet. So it's, I would say same level, maybe just a little, but definitely medial to the anterior calcaneal facet. So anterior calcaneal facet, and then on the medial aspect, you have your facet for the spring ligament. Okay. So the neck. So the neck, I mean, surgically, the neck is important for us because think about it this way. The neck is a place where you don't have cartilage, right? You don't have cartilage. So that's where a lot of the blood supply is going to come in that for that area. The neck basically is what? It's inclined medially from the talar body at an angle about 24 degrees. This is a number that they may ask you about, the angle of talar head and neck adduction, and it's basically 24 degrees where it's inclined medially from the talar body. Okay. So one thing important to remember about the neck, if you look inferiorly at the bottom, the neck has a groove, and that's your sulcus tali. Remember, the sulci are named for the bones that they actually correspond to, not like the facets, but on the talus, the sulci is called sulcus tali. On the calcaneus, it's sulcus calcaneus. So that stays according to the bone that it is with, or it is at. So the neck forms a groove, the sulcus tali, where it meets the talar body, okay? What's important about the sulcus? You have the interosseous talocalcaneal ligament. So here's your talus, here's your calcaneus. This is a picture of the interosseous talocalcaneal ligament that is situated in the sulcus tali, okay? So a lot of the times it's hard to appreciate it when you open up the joint because you cut it. But this is a picture of it. Okay. So the body of the talus, all right, so superior surface. They do ask board questions on the superior surface of the body of the talus. Why? Because of the unique trochlear shape of the top or the superior surface of the body of the talus. It's pulley or spool-shaped articular surface, okay? What's important about it? It's wider anteriorly, okay, versus posteriorly, and it has a shallow and broad anterior-posterior groove, okay? So it has a groove over here, a shallow one, and it's broader anteriorly. And why is that important? So it is important, think about it this way, as you're sitting in your desk during this lecture and you're reviewing, okay? Think about it this way, move your ankle up and down, right? When you dorsiflex your ankle, so dorsiflex your ankle to the most maximum position you can, you find that it's a lot harder to move your foot. If you feel like your foot is locked in by the ankle joint, which is what is actually happening because the wider anterior bone structure of the superior surface of the talus, that leaves less wiggle room for you to kind of move when you're in a fully dorsiflexed position at the ankle joint. Now, if you plantar flex the ankle and you plantar flex it, you are able to kind of have a little bit more wiggle room because the posterior end of it is not as wide, so it's more accommodating. And that makes sense because think about it this way, when you're plantar flexing, you have to have a little bit of that extra motion available, okay? So a couple of quick things to mention. So we have different surfaces. We have medial surface, lateral surface of the body of the talus. The lateral surface. Remember I told you how to tell laterality of the talus by the lateral triangular articular facet on the lateral side and the comma-shaped articular facet on the medial side. So lateral surface is a large triangular articular facet for the lateral malleolus. That's how you can tell laterality. And this little tip is called the lateral process of the talus, okay? Medial surface, you have that comma-shaped articular surface. That is, remember, they are continuous with the above trochlear, but this is just a comma-shaped medially, which is for the medial malleolus, okay? Posterior surface is important. High yield, they will ask questions about it on the boards. The one question they ask very often is about the posterior process of the talus. Okay, the posterior process, what is it? Okay, it's basically a shelf of bone that is grooved from top to bottom. So here's the shelf of bone, and here's this shelf. There's a groove from top to bottom, okay? And this groove is where the tendon of flexor hallucis longus runs. It's a major board question. It could be presented in a couple of different ways. Sometimes, by the way, this is something that they did ask about. So you have to cover, when they talk about the Saidas process, right? Or sometimes what you have is sometimes you have an accessory bone that doesn't ossify to these tubercles. It stays as an independent center. So someone with a accessory bone will have an accessory bone that's like in the X-ray that floats around in this area, right? Usually people have it. Some people are asymptomatic. You know, some people are symptomatic. It bothers them. But in a situation where someone comes in and they were fine before this day, and then they had some kind of an injury and they kicked something, or they were playing sports, and they're complaining of pain in the back of the ankle area, because remember, ankle joint here, subtalar joint here, it's very close. So usually it'll present as pain in the back of the ankle area, and you x-ray them and you'll see that there's like a little irregular piece of bone sticking out. Sometimes you have a fracture of the tubercle, you know, that's in that posterior shell, posterior process. And usually the way that we could test that it is possibly a fracture is, remember, the tendon of flexor collusus longus runs in between them, correct? So if you put the big toe joint through range of motion and activate the flexor hallucis longus, when that tendon slides in the groove, and if it moves that little piece of fractured bone that's there, you're going to elicit a lot of pain. So sometimes we do that in order to check, because sometimes it's hard to tell, is this an accessory ossicle or is this a fresh fracture? So, you know, so something to note. In general, the two tubercles on the sides of the groove, the medial one is smaller, the lateral one is larger. That one has more of a tendency to, you know, break off. If it's really large, that's when we talk about the staitis process. And again, occasionally it forms as an independent ossification and remains as an accessory bone, os trigonum. Okay, the os trigonum was asked on my board, so I'm not surprised if it's going to be asked on yours. So understand this anatomy very, very well. Also, something very important to note, where did it go? Also, something very important to note is that just understand posteriorly, the ankle joint and the subtalar joint are very, very close to each other. So basically, the only thing that kind of separates that space posteriorly, right, is you have the ankle joint that finishes somewhere here. Remember, this whole surface is for the ankle joint. So you have the ankle joint. Then you have this little area with the posterior process, and right underneath it is subtalar joint. When you're doing surgery, it's very hard to kind of, you know, that's basically your posterior process is your guiding light as far as separating where the ankle joint and subtalar joint is. It's not as easy to find as people may think. Okay. Body of the talus plantar surface. So a lot of important things. So let's talk about the facets. So they could ask a lot of questions about the facets on the, you know, of the talus, just because of the terminology and the relationship. So let's discuss a couple of different things. So you have the anterior, on the talus, anterior calcaneal facet, okay, which is, I guess, if you look at this as anterior, this is posterior. This guy is most anterior comparison to the middle calcaneal facet, which is a little bit towards the middle, obviously. So anterior, middle, and posterior, okay? And medially, you're going to have the area for the facet for the spring ligament, okay? Calcaneonavicular ligament, which also is very important in supporting, we'll discuss it on the next slide. In the next lecture about supporting the medial arch. Let's see. And so remember the relationship of the anterior and middle facets, the posterior facet, there's a sulcus tali that divides them. And basically there is a interosseous talocalcaneal ligament that runs in between. All right. Describe the osseous structures of the calcaneus. So calcaneus, very vascular bone, so we don't go crazy about, you know, we should understand where the vasculature comes from, but it's not as difficult to heal as, you know, the talus. It's the largest bone in the foot, articulates with basically how many bones? It articulates with the talus superiorly, it articulates with the cuboid anteriorly, and we have the anterior end of it, which is this guy right here, anterior end of it. The calcaneus is tilted upward. There's something called calcaneal pitch. What's important about calcaneal pitch is that I believe if you look at Dr. Dickey's handout, she might have mentioned the degrees. There's various numbers. Follow the osteology guideline and the joint packet guideline for numbers, because different sources will give you different range of normal values of, let's say, calcaneal inclination or other angles. But for boards part 1, this is kind of the values that are used. You may come across different values later on, but basically whatever numbers that come out of the Dr. Dickey's packets is the numbers that they kind of accept as the normal range for boards part 1. So use those, okay? So normal calcaneus has an anterior pitch. It's tilted upward, anterior upward pitch, and that's basically to maintain a specific inclination to maintain the rest of the foot in normal alignment. Now, if you look at this picture, it looks almost like there's this off the ground component, the very cavus foot. This is just to show you how the alignment of the bones are. But in reality, when you're standing, when you're in the normal non-pathologic foot, this part is very low to the ground comparison to the medial arch. And FYI, if someone has a really, really bad collapsed foot, like severely flat-footed, this pitch is like here. There's no pitch. All right, so important is the superior surface, the dorsal surface of the calcaneus. Why? Because again, of the facets that are the talar facets. Remember, so we have, if we look at our calcaneus, right? Remember how to tell the orientation, like laterality of calcaneus, the bump, the sustentaculum tali, right? The sustentaculum tali is on the medial side, right? So here is our anterior talar facet. Sorry, anterior talar facet. This is our middle talar facet, which rests right underneath the sustentaculum tali. And again, two facets can be separate, but sometimes present as a continuous articular surface. We see them both ways in the lab, okay? Posterior to them, behind them, we have our sulcus. Our sulcus is right here, our sulcus calcanei, because it's the calcaneus, okay? And what's importantly to note about it is that the sulcus calcanei, when you look at it, it's this guy right here. This is the medial side. This is the lateral side. So the sulcus calcanei is actually very wide laterally versus medially, okay? So when the talus and the calcaneus are together, the two sulci come together, right? And they create a tunnel, and this tunnel is called the sinus tarsi, okay? And the sinus tarsi, so this is your sulcus tali, this is your sulcus calcanei, and they come together to form the sinus tarsi, and it has all these goodies, interosseous talocalcaneal ligament and some blood vessels that run in it. Okay, let's see. So if we look, so that was the anterior, so the calcaneus is divided, or we can divide it into three portions: anterior third, middle third, and posterior third. Okay, so the anterior third is what had the anterior and anterior and middle facet. So let's talk about the middle 1/3. The middle 1/3 basically has the big kahuna, the large convex shaped posterior talar facet. Okay, and that's basically a very important facet, especially when it comes to fixed calcaneal fractures. It is elevated, it's raised, and it articulates with that little concave posterior calcaneal facet at the body of the talus. So what's important about it? Let me just see if I could. So just notice the anatomy of it. So this is your posterior facet, posterior talar facet on the calcaneus, okay? And look at its angle, okay? What's important is that when you have these calcaneal fractures, this usually from the impact of the force, this guy, instead of being like this, it flattens out. So literally, when you go in to fix the fracture, you literally push it back up into this alignment. So understand the relationship, how curved and how angled this posterior facet is. Okay, posterior third. Posterior third is this guy right here, okay? And that's basically this long process here. It extends the lever arm between the ankle and the subtalar joint, and that's where the Achilles tendon inserts. So pretty much that's that. Anterior surface of the calcaneus. Anterior surface of the calcaneus. So anterior process of the calcaneus, anterior surface of the calcaneus is basically this saddle-shaped articular facet for the cuboid. And think about it. When you have a saddle-shaped joint in general, do you have a lot of movement between it? No. So this joint between the calcaneus and the cuboid is meant to be more for stability purposes, okay? Saddle-shaped, making it unique on the lateral side. All right, posterior surface. So a couple things to note, okay? So we have three divisions, upper, middle, lower thirds, okay? So in the upper third, number 18, we have a smooth area for the bursa of the Achilles tendon and the fat pad. So remember, we have the middle third, where there's a horizontal ridge that basically marks the attachment of the Achilles tendon. There's a question on the high yield topics about heel spurs. Heel spurs can be plantar. So this is the side view of calcaneus, right? So heel spurs can be here at the heel here, but heel spurs can be over here in the back, okay? Because this is the heel bone technically. So just so as a presentation of a heel spur plantarly, so I could note for you, what happens is radiographically, you see a little like peak, a little shelf of like sharp bone. That doesn't hurt. So when someone comes in with heel spur pain plantarly, right? Unless the spur is massively large or broken, the calcification, the growth of bone that occurred here is not what's giving someone pain. The pathologic of excessive pull on the plantar fascia and inflammation in the area and compression on the plantar nerve that's in the area, right? You have the Baxter's nerve, and then swelling of the plantar musculature in the area, irritation of everything in the area, that causes the pain. The heel spur itself doesn't. Heel spur is a reaction of excessive pull of the plantar fascia at the point of insertion. So same thing applies over here. Here, this is kind of what I would say somewhat of a normal insertion point of Achilles looks like. Some people have heel spurs going up, you know, and that's basically the way that it looks in intra-op is not necessarily a distinct perfect heel spur. It's just, it looks like calcifications within, you know, the tendon of the Achilles at insertion. So middle third basically, you know, marks the ridge for the attachment of the Achilles tendon. So this smooth area for the bursa and the fat pad has to be, you know, that what cushions the Achilles tendon so it doesn't rub against the upper third of the calcaneus. And obviously the lower and large weight-bearing surface of the lower third of the calcaneus to bear the weight of the foot, okay? All right, medial surface. What's important to know about the medial surface? Medial surface has this nice ridge of bone called the sustentaculum tali. It's a shelf, and the shelf on top of it bears directly on top of it the middle talar facet on the superior aspect. And another test question is right underneath it is your groove for the flexor hallucis longus tendon. Remember, so we have a groove for the FHL in the back of the talus. That's an important spot. And an important spot is the groove for the flexor hallucis longus tendon, okay? And actually, sometimes when we do surgery, so this is the medial side of the calcaneus, this is the lateral side of the calcaneus, we approach the calcaneus from the lateral side because remember, our neurovascular bundle runs medially, correct? So sometimes when we perform something called calcaneal osteotomy, where we cut the calcaneus to shift it over in the desired position, that's usually in like flat foot reconstruction surgery. So as we're cutting from the lateral side to the medial side, we go slow and we watch the movement of the foot very carefully. Why? Because our tendons run on the medial side. We have the flexor hallucis longus that runs here. We have the posterior leg tendons that run here, correct? On the medial side. What's important is that sometimes when you're about to break the cortex and because remember, in osteotomies, you have to cut through and through from lateral to medial side. Sometimes you start to activate the flexor tendons and your foot starts to flex. Then you know you've kind of reached the medial side or you went too far. So you have to be careful not to, catch the structures on the medial side of the foot of the calcaneus when you cut from the lateral side. Okay, so the lateral surface, not much to talk about there. There is a little tubercle that is on the lateral aspect that basically separates the tendon of the peroneus longus and peroneus brevis. Not much going on there. The other thing that they may talk about is that right behind so we have this little trochlear right here. So right behind the trochlear, there may be another swelling. It's not evident sometimes. And basically, so here's your trochlear, right? Tubercle. So right behind it is going to be another eminence, some evidence, some not, in some bones. And that basically, it's called retrotrochlear eminence. It's behind the trochlear. And what's important about it is that if there's an eminence, in some people it's evident and some people not, but there is something called the neutral triangle of the calcaneus. And it's in that area, so it's somewhere right here, where there's reduced trabeculation and vascular concentration. And that's very important because that is going to be where you have to watch out for like fractures. Again, we don't really generally worry about calcaneal bone healing, but this area right here is where we discuss the neutral triangle of the calcaneus because there's reduced trabeculation, vascular concentration. So that's somewhat of an area of concern, but for the most part, healing is pretty much okay. Plantar surface of the calcaneus. So a couple of things to note here. So again, we're starting to bring everything together. So which ligaments they want to know about? Plantar surface of the calcaneus. They want to know about ligaments and tendons that run on the surfaces of these bones. So the long plantar ligament, one little guy you have to know really well. Also the short plantar ligament, okay? By the way, another thing on the boards. So this is for the anatomy portion. It's written by, East Coast versus West Coast anatomists. So very important is that you have to know all the terms. So plantar calcaneocuboid ligament, aka short plantar ligament. Don't just know it as a short plantar ligament. Know it as the plantar or calcaneocuboid ligament. Depending on which podiatry school, they use all terms. And doctors take these hands out for joints, for osteology and joints. Sometimes she has in the parentheses all these different terms. Know all of them because sometimes different schools use different terms. For example, peroneus longus, fibularis longus, right? For tendons, for muscles. So same thing for joints and for ligaments. You have to know all names because they will it's a simple question, but instead of the spring ligament, for example, they'll talk about plantar calcaneonavicular ligament, and then that's when you're going to get in trouble because, oh, wait, which ligament is that? You know what I mean? So understand that's like, if you know the terms of all the terms that are listed, you will be golden for that, And that's pretty much what we use for board review, the packets. All right, so things to know plantarly. You have the calcaneus basically has a rough surface, varying large prominences. You have your calcaneal tuberosity, right? It's divided into a large medial tuber or medial process, tuberosity or tubercle. So again, it could be named at all three. Large medial process of the calcaneus, large medial tuberosity, large medial tubercle, okay? And a smaller lateral one. What's important for it? Because these processes, these tubercles, this area provides attachment for the intrinsic muscles of the foot. That's another test question that they could ask. All the following muscles come off the medial tubercle and the lateral tubercle, except for the following muscles come off only off the medial tubercle, tuberosity of the calcaneus, except for all the following muscles come off the lateral process or lateral tuberosity of the calcaneus, except for. So these types of questions. All right, and So that's, you know, that's your large medial tuberosity or tubercular process, whatever you want to call it, and the smaller lateral one. Now, anterior to it, so distal to it, number 13, right over here, is your anterior tubercle, another pump. And basically, that's another way where it's very important because that's the attachment for the long plantar ligament. Okay, and is it why? Because it's located just, you know, past this point of tuberosity. So here's this large anterior tubercle. So you may be asked to identify that as well. Okay, number 14. So look at that. That is your sustentaculum tali. So this is the groove for the FHL. I mean, it could be as easy as identification questions. Last time I checked, they don't make them very complicated story questions, but if you know the basics, sometimes it's presented in a clinical format or sometimes there's a long story, but the answer is still really quick and easy. You know, if someone cuts through this portion of the calcaneus accidentally, or there's a fracture, what tubercle is, you know, they could give you a whole story about a fracture or trauma or incident, and the end question would be, what structure is affected? The anterior tubercle, you know, things like that. They tend to do that. Same thing here, subtalar joint. Subtalar joint has different names, okay? Posterior talocalcaneal, posterior subtalar. There's different types of, you know, terminology that's used for it. So again, use Dr. Dickey's package just to be comfortable with all of it, okay? So what is the bony structure? So concave posterior facet of the talus, convex posterior facet of the calcaneus, bordered anteriorly by the sinus tarsi, and the two sulci which form it. So right now, when we talk about an so when we talk about a joint that we want to fuse. So when we talk about subtalar joint fusion, you're going to learn a lot about it in surgery. When we fuse the subtalar joint in real life as podiatrists, this is the joint we're going for. We're going for the joint between the posterior facets of between the talus and the calcaneus. That's our true subtalar joint, and that's what I was telling you guys beforehand. Let me see, where is it? Like, for example, when we have pathology and we have severe arthritis, the joint that we usually target to fuse or we throw a screw across would be the posterior subtalar joint, or this, we call that subtalar joint, but it's technically posterior subtalar joint. And that's the posterior calcaneal facet here, posterior talar facet here. That, you know, this unit is fused. Okay, so get a break for a few minutes. We might go over a little bit of 2 hours, 5 to 15 minutes. I'll try to cover as much as possible. I just want you to have everything. Okay, so let's talk about a couple of different things. What's important? So you have a couple of ligaments that Dr. Dickey also likes to discuss, and they do ask questions about it. So it's some things are going to be random that I'll just throw in that are kind of part of the topic in that area, for example, surrounding that specific joint. So important to remember, okay? So we have a posterior talocalcaneal ligament. Posterior talocalcaneal ligament is basically a ligament between the talus and the calcaneus posteriorly. So this is a good picture, posterior talocalcaneal ligament. Why is it important? Because it covers and straps in the tendon of flexor hallucis, longus in the groove. So if they ask you a question about the posterior talocalcaneal ligament and its orientation position, so this is a good picture just to show you. You have flexor hallucis longus running in this groove and then basically strapped in by the posterior talocalcaneal ligament. Then we have the lateral talocalcaneal ligament. I mean, again, we're talking about subtalar joints, so we're talking about basically the ligaments that go from the talus to the calcaneus, right? So we have our posterior talocalcaneal in the back. So let's talk about the lateral talocalcaneal. So the lateral talocalcaneal ligament is about this way right here. Okay. So basically, it's on the lateral side. It's attached to the lateral process of the talus and the lateral surface of the calcaneus. So when we talked about the talus, the lateral surface of the talus, we have the lateral process that's right here. Okay. So the board question could be, what attaches to the lateral process of the talus? So basically, that's going to be the lateral talocalcaneal ligament that runs from that lateral process over here, and it inserts onto the lateral surface of the calcaneus. And what's important about it, it is deep to the calcaneofibular ligament. So remember, your lateral collateral ligaments, and we'll talk about them, your lateral collateral ligaments, laterally you have the ligament running from the talus to the calcaneus, your lateral calcaneofibular ligament. So deep to it is your lateral talocalcaneal ligament. So understand how they layer each other, okay? Another important thing to note is, I will reiterate it, is that lateral collateral ligaments, with exception of the calcaneofibular ligament, in surgery, you can actually see the calcaneofibular ligament as a distinct entity. It looks like a little, I would describe it as like a robust fettuccine, or like, yeah, like a robust fettuccine. You can actually see it. The other ligaments are part of the capsule. They're like reinforced, thickened parts of the capsule. You really can't see them. You just kind of have to know where the location is. And when you're tightening or fixing, let's say the ATFL, you're basically reinforcing the capsule in that area, which will have the ligament. So remember, extracapsular, intracapsular, so calcaneofibular is extracapsular. Okay, so then the third ligament between the talus and the calcaneus is your medial talocalcaneal ligament. And the medial, here's the picture of it, medial talocalcaneal ligament. And basically, it's attached to the medial tubercle of the talus. Remember, lateral tubercle, your groove, medial tubercle. So it's attached from the medial tubercle of the talus to the posterior aspect of the subtentaculum tali. What's important about it is that its fibers may blend with our spring ligament that we'll discuss. Okay, and that's very important because it provides a little extra support on the medial side, right? Also the medial collateral ligaments. Again, everything is the capsule is basically a bunch of ligaments that are within the capsule, which are, I would think of them as reinforced parts of the capsule. Whatever is intracapsular is more or less like a reinforced part of the capsule. So all these ligaments, you're not going to be able to see them distinctly, or very lucky if you are, but for the most part, when you're fixing them, again, you're like repairing those areas of the capsule and tightening those areas of the capsule that have been torn or attenuated. Okay, interosseous talocalcaneal ligament, we discussed already. What's important about it, okay? We'll discuss it in more detail, but you have your interosseous talocalcaneal ligament, which is basically between the talus and the calcaneus. And it's oriented in the way how the joint is oriented, like that pathway of the joint is oriented. And what's the most important thing about it is that the interosseous talocalcaneal ligament limits eversion or pronation of the subtalar joint. You could read about it. I made a distinct slides about it so you could just read along. All right, cervical ligament. Cervical ligament is considered part of the interosseous talocalcaneal ligament. So remember the sinus tarsi. Remember, we have the canal that's created by the talus and the calcaneus, right? The sulci create a canal, the sinus tarsi. And medially, it's laterally, it's a lot larger than medially. Okay, medially it's a little hole, but laterally it's a large area. Okay, so this interosseous, like talocalcaneal ligament, the portion that peeks out that you can see surgically without opening up the subtalar joint, like opening up the, the interosseous ligament within the sulci, that portion is usually called the cervical ligament. So technically it's continuation of the interosseous ligament, but it's the portion that is visible when you do surgery in the area and you could see it. So that's the cervical ligament. So they're all continuous, okay? What's important to note is that so this is your talus, this is the lateral side of the talus, correct? So basically the cervical ligament attached to the lateral side of the neck of the talus. So that's another board question. Which ligament attaches to the lateral aspect of the neck of the talus, okay? So that's your cervical ligament. And basically it attaches to the anterior superior surface. So this is anterior superior surface of the calcaneus, okay? So that's the attachment points, okay? Let me see. That's about it, what we need to know. So they will ask what's the continue. Sometimes the board question will be like the cervical ligament, all the following are true except, and it'll be like it's a continuation of the interosseous ligament, and they'll talk about its attachments. It's attached to the lateral side of the neck of the talus. It's attached to anterior superior surface of the calcaneus. So questions like that. You could get a lot of questions from just that area. Okay, so describe the formation axis motion of the functional subtalar joint. So subtalar joint. So we discussed the anatomical subtalar joint, and now let's talk about the functional subtalar joint. Okay. Reason what you guys learn about functional joints versus anatomic joints. When we talk about functional joints, is that joints are never isolated in the foot, right? One joint affects the movement of another. So when we talk about functional subtalar joint, or all these joints are important in working together, even though there's a separation by capsule or by a structure. The reason why they're important is because they work together to produce a certain necessary or essential motion. Basically, with one kind of motion, this happens in this area of the foot. With this type of motion, this happens in this joint as well. So for functional subtalar joint, it includes all 3 pairs of talocalcaneal facets without regard to the location of joint capsule, okay? So what this means is that functionally, all these 3 facets on the talus and the calcaneus work together, okay? Why? So this is your posterior facet that is located on the calcaneus, so it's your posterior talar facet. So when the talus and the calcaneus, when they move on the posterior facet, let's say only, right? The anterior and middle facets also have to move. They're not independent, okay? So even though you have your posterior facet that is separated from your anterior and middle facets by capsule wall, by these ligaments, the interosseous ligament and sinus tarsi, which kind of separates the 2 areas. In one motion, the other facets get affected. So functionally, we classify them as all these middle, anterior, and posterior calcaneal and talar facets together as a one functional subtalar joint unit. So remember, one functional subtalar joint is made up of anatomical posterior subtalar joint and 1/2 of the talocalcaneal navicular joint, right, which is your anterior and middle facets, okay? And what's important is the presence of the interosseous ligament and the cervical ligament, which keeps the 2 bones strongly tied together, controls the movements between them, okay? And remember, that's where it all comes in here. Interosseous talocalcaneal ligament, board question, it limits eversion pronation. All right, this you guys could read. So functional subtalar joint. So this is basically, they could ask you about position of the joint axes, of rotation around the pronation, supination movement occurs as it's, basically these are just the numbers. It's a spit back question, but these are the numbers that you just have to remember for this type of board exam. ankle joint ligaments, pretty much self-explanatory. Ankle ligaments, you have your lateral collateral, your ATFL ligament.
Dr. Block, you keep like coming in and out of audio.
Can you hear me now?
Now, yeah, but I don't know what you said before.
Oh, sorry. Where did you guys lose me?
When you were saying that it was self-explanatory and you have the anterior.
Okay. So the lateral collateral ligaments, so the lateral collateral ligaments on the boards, they could discuss, they ask questions as far as the boards about, even though a lot of the ligaments in the ankle are within the capsule, right, intracapsular, they still ask about to which bones they attach to, how, and with some of them they'll ask about injury, and some of them they'll ask about, surgical procedure. If you approach from this side, what will you cut? So they could ask questions in a couple of different ways. So for ATFL, anterior talofibular ligament, you guys could, you could review the insertions by yourself. But what's important about it? Of the lateral collateral ligaments of the ankle, it's the shortest of the lateral ligaments, and it's the most commonly injured in plantar flexion and inversion sprains. So when someone comes in and they sprain with a sprained ankle, one of your most common ankle injuries that will come in is an ankle sprain, right? They sprained it, they try to ice it for a few days, not walk on it, it's not getting better, they end up in your office, a couple of days later, unless it's like an ankle fracture where it's swollen and they can't walk. So the one ligament we bet on injuring is your ATFL. Okay, and that's the weakest, and that's the shortest, and that's what gets injured. So that's the board question. ATFL obviously is capsular, right? And so will you see it as a distinct little line? No, it's within the capsule. And when we have to repair it, we repair the capsule with it. But again, inversion sprain injury, most common ligament injured, ATFL. Okay, calcaneal fibular. Calcaneal fibular is different. It looks like a little fettuccine. You can actually see it. It runs from your calcaneus to your fibula on lateral side, right? You could actually see it. It's distinct. It's capsular. Cord-like in shape. I believe that's the second most, after the ATFL, the second one to be injured, if the sprain is worse enough, is going to be your calcaneal fibula. Okay. Posterior talofibular ligament. It's the strongest of the lateral collateral ligaments. So if in the order of injury of a lateral ankle sprain, which is one of your, it did ask, there was clinical aspect. Let me see, what was the describe the anatomical basis of lateral ankle sprains. That was one of the things that was covered. So they'll ask you, what's the order of injury as far as ligaments? So you're on lateral, for inversion sprain, your ATFL will get injured first. Then it's your calcaneal fibular, and the last one, if it's going to be injured, is your posterior talofib. Usually it's not, because it's pretty strong of the lateral ligaments, but the most common you see on MRI after a lateral ankle sprain would be your ATFL and CFL. All right, deltoid ligaments, medial collateral ligaments. So basically you have your superficial group, and you have your deep group. You could read about those. Let me see. So there's various textbooks use different types of, they divide it differently. So in literature, when you're gonna have lectures later on about deltoid ligaments and repair, we could have many different variations. So some identify somewhere between like 4 or 5 up to 9 segments of these medial collateral ligaments. In general, when you're repairing them, they're pretty much like within a capsule, so you have to repair the whole process. But for now, in podiatric anatomy, typically we, like as far as testing is concerned, we have 5 medial collateral segments that are described, 3 superficial and 2 deep. So you're going to come in in contact with literature from Europe, from other parts, from Japan, where they're going to describe different parts and different numbers. So for podiatry, for boards part 1, you have 5 medial collateral segments, 3 superficial, and 2 deep. Okay, so your superficial, here it is. You could review it. It's nothing crazy. You have your tibio. So you have your tibio-navicular component right over here, tibio-calcaneal and posterior tibio-talar ligament. There is a superficial and then there's a deep component, so just be aware. It's all about memorization, okay? It's all blending in with certain. The other thing you have to note is that sometimes they'll mention this ligament blends in with another ligament. Oh, everything you could read here just to reinforce it. I just want to move on forward so we could have. Oh, another thing to know, the calcaneal-fibular ligament and tibio-calcaneal ligament in the ankle region, right? Remember, they cross the ankle and the subtalar joint. So these 2 collateral ligaments help stabilize the movements of the subtalar joint immediately below the ankle. So these is also another test question that can be asked. Which ligaments cross both joints, the ankle joint and the subtalar joint? Okay, ankle function. So all of this is going to be just for you to read. So this is, they may ask about it. This is just self-explanatory. So let's just do the next one. I don't want to cover as much as possible. This is a long one. They're going to get shorter. Board part 2. And board part 5 is like a hodgepodge. You guys could review on your own. I just put the information together. If you can't hear me, just let me know. Okay, osteostructure of the navicular. All right, so you guys, let me just see. Okay, a couple of things. So basically these are good pictures combined with Dr. Dickey's notes. This is my lecture notes. So I'm just gonna fly through some things that are important. Okay, so you guys know the anatomy of the navicular. What's important? A couple of things are important. So medial surface, which, medial surface basically has this bump, which is a continuation of the dorsal surface and medially becomes a big bump, which is your navicular tuberosity. What's important about it as far as the boards, the tuberosity provides attachment for most, not all, but most of the tendon of tibialis posterior. The tendon of tibialis posterior muscle, it kind of fans out in the foot, right? The big attachment occurs at the navicular tuberosity, but it's not all of it, but most of it. So when we do surgery, sometimes we have a huge enlarged navicular tuberosity that we have to cut. We have to detach the tendon and then reattach it, right? So remember, most of the tendon, vast majority of tendon attaches there, but not all of it. It still fans out to the other areas of the foot, okay? So here is an example of that. Your tibialis posterior tendon, most of it attaches to the navicular tuberosity, but some of it fans out into other areas. So what's another important thing? So navicular. So over here, so we have our navicular tuberosity. Plantarly, we have a groove, okay? And we have a groove for what? We have a groove that is for the remaining part of tendon of tibialis posterior, right? So it attaches here in this part, and then all rest of it flies in this groove and into the rest of the bones of the foot. So here is how it presents. Okay, so the groove. So if they tag this area on the plantar surface, that's for the groove of tendon of tibialis posterior. Sometimes they just ask. They give you a bone and they ask. Okay. Oh, by the way, so this is something that just be aware. The boards are not perfect, and sometimes, don't freak out, just make a note. Sometimes there were situations where the multiple choice of the question, like you were given a question about the navicular and the multiple answers did not match the question. It was something else. I've had it pretty much a hiccup of that type of sort on pretty much every one of my boards. 1 or 2 questions did not make sense. All you have to do is note the question, and then at the end, if you have time, in the message board, you write it down, and in the message board, you say that this question had a wrong answer set. That may happen, so don't freak out. On my boards part 1, at the end, we had like multiple match where you just drag and match like couple of questions. Mine was about cranial nerves, like the pathway of the cranial nerve. So the two last questions before the ending, completely the question and the answer didn't match. So don't freak out, it will happen. Just note the number and email and text, like in your comments, write that this was incorrect answer, question, mismatch. They will throw that question out, okay? I did it first time, I freaked out, and then we all did it, and then they throw those questions out. So don't freak out. It's not like you're gonna lose points. It's better for them just to be aware of that. So if you have a little board, just write it down on the board, like question was wrong. You don't have to go into detail, just say it didn't match or the picture didn't show. Sometimes they'll give you a picture and the picture doesn't pop up. So just be aware of that. Don't freak out. Nowhere near perfect. Okay, so let's see. So pretty much you could read about the navicular, but I'm just gonna hit high points. So describe the formation. Again, this is more of your study guide. So I'm gonna hit high points, but you're gonna have to go in and review in detail. Formation, ligamentous structure of the cuneo-navicular articulation. So important thing to note is basically they will ask about how the articular surfaces will look like, right? So if you look at the navicular anterior surface, which articulates with the cuneiforms, they'll ask how are the articular surfaces divided and how do they look like, right? So what's important thing to note is that the medial facet, which is for the medial cuneiform, is basically broader inferiorly and the apex is superiorly. The other two, the apex is inferior and it's more or less broader superiorly. So the tip of the triangle is superior at the first, and the tip of the triangle is on the bottom of the other two. This one looks kind of almost rectangular, but that's what they describe it as, okay? So something to just follow. They may ask about that. Okay. All right. Describe the formational ligamentous structure of talocalcaneonavicular articulation. So basically, the talocalcaneonavicular articulation, we'll take into account what? We take into account components of the talocalcaneonavicular joint. We're going to talk about the articulations between the talus and the calcaneus, which is your anterior and middle facets. And then we're also going to talk about the articulations between the talus and the navicular. So together, they all combine the talocalcaneonavicular joint. The representation, calcaneus, navicular. Okay, there's a lot of things. So what's important to know? All right. Subtalar joint is part of the functional subtalar joint. All right. So the one important thing to note is you have different parts of the talocalcaneonavicular joint has a talonavicular part, and it also has the talocalcaneal part. Okay. So the anterior subtalar, which is your anterior and middle facets, are part of a functional subtalar joint. Remember, because that includes all three. And the talonavicular part is part of the functional McTarsal joint. Because when we talk about talocalcaneonavicular, it's one unit, right? Because of the capsule and stuff. So then they may ask about these components as well. All right, what else do I need to know? This is another thing that we have to know. So between the sustentacular and navicular attachments, the capsule is reinforced by the capsular spring ligament. So we know that the spring ligament plays a very important role on the medial aspect of the talocalcaneonavicular joint. The other thing to note is that there is so tibialis posterior tendon runs on the medial aspect and basically helps to reinforce the pressure of the tibialis posterior, helps to support the medial aspect. So this basically is a sentence that, you know, talking about support of the medial wall of the whole complex and which tendons support it. Again, something that should be noted as you review each muscle and tendon component. All right, this is a lot of stuff. This is all. Okay, the bifurcate ligament, they do ask about that. The bifurcate ligament comes in two parts. It's the calcaneonavicular ligament, calcaneocuboid ligament. So they will ask about the insertion of which part into which bone. That is something that they do ask on the board. So understand the bifurcate ligament very well. Okay, osseous structure of the cuboid. Okay, pretty much self-explanatory. Not much to discuss. You guys could read it. They do ask about the cuboid and the shape of the articulations between the fourth and fifth metatarsals. We reviewed that in class, but this is pretty much that. Okay. Let me see. So one important thing to note is articular areas with the anterior process of the calcaneus. So we know that's the saddle-shaped joint. So it locks it in. It's not as free moving. So that provides stability on the lateral side. Articulation between the fourth and fifth metatarsal. Another thing to note, if you look at the lateral surface and you compare it to the medial surface of the cuboid, look at the lateral surface. It's pretty small. The medial surface is large, okay? And the medial surface is, one board question could be, is, the longest side of the cuboid. And that's the medial surface of the cuboid, okay? And basically, what articulates with the medial surface of the cuboid? So you have articulation with what? You have articulation mostly with, or definitely present all the time, articulation between the cuboid and the lateral cuneiform. Sometimes, not all the time, but sometimes you do have this little facet in this area of the cuboid that you have a little articulation with the navicular. It doesn't happen with all people, but sometimes it is present. So if you look at the medial side, so this is front, anterior, this is medial, fourth and fifth metatarsal articulation areas here, but look at it. So there's a large facet medially for the lateral or third cuneiform, and then sometimes occasional facet for the navicular. Okay. All right, things important to note. So what do we have? The lateral surface is the shortest side. We could see it over here when it's articulated. Look at this side, look at this side, compare this side and this side. So this guy is the shortest side, the lateral side, and we have a peroneal notch, okay? We have a notch over here and the notch over here, and it continues as a groove. For the peroneus tendon, for the peroneus longus tendon, okay? So that's very important to note. And then behind the notch, we have something called peroneal tubercle or cuboid tuberosity. So that's this guy right here. So notch is here, groove is here, peroneal tuberosity is here, okay? Tuberosity, notch, groove, tuberosity. Okay, importance of that, you have the cuboid tuberosity that may arise as a second, as an accessory bone and not fused to the cuboid, and you end up having os peroneum. So basically, you have the notch, you have the groove, and in this case, if there's no pain and no history of injury, you had this cuboid tuberosity that had a secondary ossification center that never ossified, and you end up having this accessory bone, os peroneum. Okay. Let me see what else. Inferior surface. We have the peroneal groove or peroneal sulcus. Okay. That's pretty much that. So they'll ask like what tendon runs in the groove. They could ask about the asperonium. They could give you an X-ray. Remember, if you don't have previous X-rays, for the most part, fractures of the cuboid don't look like this. So if you have an X-ray that is this, that's your asperonium. Okay, calcaneocuboid joint. So calcaneocuboid. Calcaneocuboid is your joint between the anterior calcaneus and the cuboid. It is saddle shaped. We talked about it provides more stability. There's ligaments. You have ligaments on the dorsal side. You have ligaments on the plantar side. They're called dorsolateral calcaneocuboid ligaments. You guys can read about it. What they do test about is the bifurcate ligament. Now, the bifurcate ligament, so part of it goes from the calcaneus to the navicular. So that's not that part that we want to talk about as far as respect to calcaneocuboid joint. For the calcaneocuboid joint, we talk about the calcaneocuboid component, which is going from the anterior aspect of the calcaneus to the dorsal aspect of the cuboid, okay? Dorsomedial margin of the cuboid. And that's component, that's one component of the bifurcate ligament. Long plantar ligament, we discussed it already, goes from, basically another thing is could ask about the longest ligament in the foot. So that's a long plantar ligament. That might be one of those, like the following are true for the long plantar ligament, except whatever. Attaches to multiple things. So the point of attachment of the ligament is that distally it goes, to that cuboid ridge or the promontory plantarly, and then attaches to the bases of metatarsals 2, 3, and 4, and sometimes 5. So it just spreads out. Okay. Something to note. I mean, this is directly out of Dr. Dickey's stuff. Short plantar ligament. This is a good picture of it. Okay. So it basically goes from the anterior tubercle of the calcaneus. It goes anterior and attaches to the cuboid at the cuboid beak or the cuboid tuberosity. Okay. Intertarsal ligaments, we don't really identify them in surgery, just be aware that they exist. Intertarsal ligaments are ligaments between the tarsal bones. Okay. Mid-tarsal joint, so functional mid-tarsal joint. So we have a lot of components of the mid-tarsal joint. So when we talk about amputations, you must have heard of like Chopard's amputation, which is basically amputation across the functional mid-tarsal joint. So we just have to be aware of what that includes. So when we talk about mid-tarsal joint, functional mid-tarsal joint, it basically is the transverse tarsal joint line here involving these joints. And then when we talk about tarsometatarsal joint, it's also called the functional Lisfranc joint. By the way, don't mix up Lisfranc joint with Lisfranc ligament. That is going to be across the tarsal metatarsal. You could read about it, the axes and the what it allows, what it limits, and things like that. These are just direct test questions. Let me see. Okay. Again, I'm flying through this. So what I did was I basically answered the high points. I mean, you could add more information. Most of the information, like that, came from the ligaments packet and osteology packet. So you have some guidance, but feel free to add to it. Okay. So cuneiforms. We know there's middle, intermediate, lateral cuneiforms. You can discuss the shape of them. All right, what's important thing to note is that for the intermediate cuneiform, it's the shortest. It creates, this is the shortest, it creates like a locking mechanism for the second metatarsal base, more teeth that locks the second metatarsal in place, creates stability, and that becomes like the center of the foot. You could read about the medial cuneiform. Okay, so the medial cuneiform as attached ligaments, tendons, things like that. So if you look at the medial cuneiform, on the medial side of the medial cuneiform, right? So we're talking about medial aspect of the medial cuneiform. There's going to be a facet, anterior inferiorly, for the tibialis anterior tendon. That's actually a board question, okay? So just be aware what points on the bone things attached to, okay? So anterior inferiorly on the medial side right here is going to be attachment for tibialis anterior tendon. They may present it in the form of a question during surgery. Well, actually, let me just put it into the slideshow. Plantar surface. Plantar surface. What's important about the plantar surface of the medial cuneiform? Well, you have your tibialis posterior tendon, right? That's number 27. So we know the tibialis posterior tendon, the main attachment of it is to the navicular tuberosity, but it attaches elsewhere. If you could see it in this picture, you see that it attaches to the plantar surface of the medial cuneiform, and it also has these areas of attachment to the bones here. So a board question could be, where does the tendon of tibialis posterior put its fibers on the medial cuneiform? And the answer will be plantar, medial. Like, so you'll have to know that medially we have it for the attachment of tibialis anterior, plantar we have it for the tibialis posterior, things like that. Okay. The medial cuneiform. So the medial cuneiform, a lot of facets that occur between the medial side and the lateral side, where it articulates with the medial cuneiform and the lateral cuneiform. Sorry, I was talking about the middle cuneiform. So the medial cuneiform. Another thing to note, intermediate or medial cuneiform. You're going to have a lot of articulations on the medial side of it, on the lateral side of it, right? Between that articulate with the medial cuneiform and the lateral cuneiform. I don't think you really have to know what the shape of each articular area is. I'm not sure how much detail you may need to know for that. It's more about the attachments. So, sorry, I got ahead of myself. So for the medial cuneiform, another thing you have to know is that, so we discussed the medial surface. We have an area of attachment for tibialis anterior. Plantar surface, where we have the attachment for the tibialis posterior, and now we have the lateral surface. So the lateral surface is actually, it's hard to see in this picture. So the lateral surface of the medial cuneiform. So lateral surface of the medial cuneiform. We're going to have a facet there for the insertion of the peroneus longus tendon. So peroneus longus tendon runs from the lateral side of the foot and shoots over to the lateral side of the cuneiform. So another medial cuneiform. So another test question would be, okay, so tell me, how many tendons, all of the following tendons insert into the medial cuneiform except. So remember, infero-medially, tibialis anterior. Plantarly, and I guess proximal plantar, you have your tibialis posterior. And then inferolaterally, obviously it has to be inferolaterally. And remember, they could ask dorsolaterally or inferior laterally. So obviously it's not the top of the medial cuneiform, but inferolaterally, you're going to have insertion of the peroneus longus. Okay, so which is like this guy right here. So that's very important to understand tibialis anterior, tibialis posterior, peroneus longus. This is something that they do ask questions about. Okay, medial cuneiform, its articulation, this is important articulation with the metatarsal, its kidney shaped reniform, and that's, sometimes they don't use the word kidney, they use reniform. Again, all the terminology Dr. Dickey listed, you have to know it. Just follow the, again, I heard this information as out of the packets. So for the most part, so just follow that along and know all the terminology. Intermediate cuneiform, they could ask questions about it, comparing. So remember, cuneiforms appear at different times, right? Ossification. So the question could be, all of the following are true about the intermediate cuneiform, etc., right? And basically it will be, they'll talk about ossification of it. They could give you the right number or the wrong number. They could talk about the size of it. So the intermediate cuneiform is the smallest of the three wedges, is the largest of the three wedges, things like that. So just be aware of all these things. They combine things together. Okay, so if you look at it, you could see that it's a small triangular little wedge. Let's see, and the articular surface is a triangle with the base dorsally and the apex plantarly, and that corresponds to the second metatarsal. You could talk about the medial and lateral sides of the intermediate cuneiform, about the articular surfaces. They may ask, I don't know how much detail they go into, I don't remember personally, but it's good to know for you when you're doing surgery on these things. Lateral cuneiform. That's another question to ask. The lateral cuneiform, and all of the above is true except, and they'll talk about ossification of it. They'll talk about articulation of it, like it articulates with 6 bones or 5 bones. So you have to really remember like what it articulates with. So like remind yourself. Let me see. You could read about it. This is just, okay, intertarsal ligaments. So you're going to have a lot of intertarsal ligaments between the tarsal bones. And know that they exist. You don't have to know their names. Okay, like they exist, but are they important to us? Yeah, they stabilize the foot. If you cut every intertarsal ligament, the foot will fall apart. But for the most part, we don't have to know them specifically or separately. We have to know that they exist. Okay, so let me see. This is talking about lateral tarsal metatarsal joints, medial tarsal metatarsal joints. You can read about it. The one important thing to note is that there is no regular, so it's not 100%, nothing is guaranteed, but there's no regular connection between the bases of the first 2 metatarsals, not the heads, because you have transverse ligaments that run there, right? But as far as the bases of metatarsals, there is no regular connection between the bases of the first 2 metatarsals. Okay, though there may occur a fibrous connection, burst, or small articular facet for the most part. So that's a test question. There is no regular connection between the bases of the first 2 metatarsals. It's literally straightforward like that. Okay, guys, don't mix up. There's Lisfrank's ligament and Lisfrank's joint. Okay, so when we talk about trauma that occurs between the metatarsal bases and tarsal bones, sometimes we have trauma where the fracture or trauma occurs where the forefoot or basically the metatarsals are like shifted off the rest of the foot, and that's what we call a Lisfrank's joint injury. Okay, it could be this part here that's broken, torn, moved, this part here, the whole thing, whatever. So don't mix up Lisfrank's joint, which is a functional tarsal metatarsal joint, which is basically between all the metatarsal bases and the tarsal bones, versus Lisfrank's ligament. Okay, so functional tarsal metatarsal joint is basically a Lisfrank's joint, which is between the metatarsal bases and the tarsal bones. Okay. That's then very important point. Lisfrank's ligament. This has been a question on every boards forever. Please know how it orients itself and where it's located. So a Lisfrank's ligament is an interosseous ligament. Okay, it's an interosseous ligament. So it's between. It runs from the lateral side of the medial cuneiform to the medial side of the base of the second metatarsal. There is no, so it goes from the medial cuneiform to the base of the second metatarsal. It literally asks you orientation and attachment points of the Lisfranc ligament. It's one of the strongest tarsometatarsal ligaments, okay? When we are concerned about injury between the tarso-metatarsal area, especially in the first ray area and here, Lisfranc syndrome, we always look for the integrity of the Lisfranc ligament. If the Lisfranc ligament is torn, then we are in trouble, and it's kind of more like emergent surgery to fix because we lose the stability of the medial column. Okay, so Lisfranc ligament interosseous. So they will ask the following are true about the interosseous Lisfranc ligament, except it's an interosseous ligament. It is attached to the lateral side of the medial cuneiform to the medial side of the basal second metatarsal. It attaches from the. They could also give you like false choice. It attaches from the medial side of the intermediate cuneiform to the base of the first, which is wrong. So that's how they'll form the question. That's how we had the question formed. So remember, interosseous comes off the lateral side of the medial cuneiform to the medial side of the base of the second metatarsal. That's it. It anchors the first ray to the rest of the foot. If it's broken, you're in trouble. You got to fix it. It's emergent. Or urgent. Not emergent, but urgent. You can't, otherwise you're going to have stability. Let's see. Other tarsometatarsal ligament. Cavities, synovial cavities of the foot. It's written in your joints packet. You could just go over that. Three types of synovial cavities. So let's just do this. Okay. So part 4 is good, and part 5 is hodgepodge of everything. Also, if you have any questions, you can email me, drmariannabloch@gmail.com. I'm checked that email multiple times a day versus the NYCPM. So if you want like a little phone session or a few things to clarify, you could always just text me message me the questions, and I could spend 5-10 minutes on the phone with you explaining. So if you're stuck on something. So when it comes to metatarsal phalangeal joints, interphalangeal joints, so a lot of high yield stuff, you have to understand your relationships. This is a good chart as far as the tendons, their location versus the ligaments versus where they're located on the metatarsal. So this is a good image just to understand. You have to be comfortable knowing that relationship going into the exam. So osteostructures of the metatarsals, we know that they do ask about metatarsals. It could be simple questions like, which of the following are true except? The first metatarsal shortest, most robust, second metatarsal is the longest, fifth metatarsal bears a prominent palpable tuberosity, easy questions to give, but just understand, by now you should be familiar with them. Also, understand, the shapes of the base of the metatarsals and how they correspond to the articular surfaces on the cuneiforms and the cuboid. All right, one question they will ask, and for some reason there's a lot of mistakes on it, but surgical neck versus anatomical neck, okay? Metatarsals have these little tubercles, okay? These little tubercles, the metatarsals heads have these little tubercles, basically to which you have ligaments, stabilizing ligaments that attach. You have collateral ligaments, just like you have collateral ligaments in the ankle, you have collateral ligaments in metatarsal phalangeal joint and interphalangeal joints, right? So these tuberosities is where you have collateral ligament attachment. So surgical neck is an area between so this is your articular surface, this is your tubercle, the surgical neck is in between, okay? Anatomical neck is just proximal to the tubercle. It's literally a board question. So understand, and they will ask which of the following is, the correct definition or whatever. Okay, things to note about the first metatarsal. First metatarsal is that, again, Another thing, if you look at, this is your first metatarsal, this is your medial aspect, this is your lateral aspect. Medially, the medial plantar corner is marked by the insertion of the tibialis anterior. We said it's on the medial cuneiform, and the medial plantar aspect of the base of the first metatarsal is the insertion point of tibialis anterior, medially. This is the medial side. Laterally, the base of the first metatarsal is obviously adjacent to, the base of the first metatarsal is adjacent to the base of the second metatarsal. But usually it does not, doesn't mean 100%, but usually it does not form a synovial joint with it. And it bears no articular facet. So that's something else they may ask. Another thing is that the metatarsal, the metatarsal head of the first metatarsal has the crista, right? Which separates the two facets for the sesamoids. And usually the medial facet is larger, usually, but sometimes it's not. Also, the base is kidney shaped, okay? Second metatarsal, the base is triangular shaped, okay, for the intermediate cuneiform. And let's see, you can read about the facets. The other thing is to start noticing is that as far as the lesser metatarsals, the shaft area, the medial side and the lateral side of the shaft, which metatarsal gives origin to which interossei muscle, okay? Big high yield thing. So the following true about the second metatarsal: it has a triangular facet for intermediate cuneiform, A. B, the medial side gives origin to the first dorsal interossei. Okay, true. The lateral side gives origin to the first plantar interossei. False. So that's how they're going to ask the questions. So know that. Let me see. Third metatarsal, triangular facet. Again, same thing. What's to know about third metatarsal is that, again, origin on the shaft of the second dorsal and first plantar interossei. That alone could confuse you, but it's easy, simple questions to get right if you just understand the information. Fourth metatarsal, what differentiates it? It has a more of a quadrangular facet, right, for the cuboid. And basically, the third dorsal and the second plantar interosseous muscle arise from the medial surface of the shaft, and the fourth dorsal interossei arises from the lateral side. That alone gets people confused. I would sit down. By the way, what I would do is before the boards, like something high yield so I don't get mixed up or nervous about. Something just remember, when you walk in on the boards, if you have that, I don't know if you get the board or you get the like paper and pen, but I would just draw out the 5 metatarsals and label like off this medial side of the second metatarsal, lateral side of the second metatarsal, which interossei originate from. Just go in, label it, leave it on the corner somewhere so it stays there. Have it fresh in your head, so then you don't have to start doubting yourself on the exam, because you're going to have a few questions with the dorsal plantar interossei. Fifth metatarsal, base of the base is triangular, like a sideways triangle, right? Sideways triangle. I like to think that the apex is like right here. Os vitellianum, accessory bone, things like that. So again, and gives rise to what? Medially, we have fourth dorsal and third plantar interossei. These are just test questions right here. They will ask more than one. And sometimes it's direct because it's easy to even mix up in your head which one is which. That's what I'm saying. Draw the chart, and so you could just have it in your head. So whenever you have to refer to, you already have it written out, because you're going to have at least a couple questions on that. Okay, phalanges. We already know a lot about phalanges at nausea, their shape. They won't so much ask about, they may ask about the shapes of it. So they may ask about the shape of the base of the proximal phalanges. They may ask about the shape of the head of the proximal phalange, the shape of the middle phalanx, and the shape of the distal phalanx. They're more interested probably talking about what inserts at what point, what inserts at the middle phalanx, what inserts at the distal phalanx, things like that. You know, that's more of a high yield question they'll ask. Let me see. Okay, so this, another high yield thing, I'm just gonna, remember interosseous Lisfrank's ligament between. This looks superficial, but it's interosseous. I just want to make that point across. You could review the structure of the metatarsals, the types of joints they form. This is a very high yield thing. Plantar plate. Plantar plate, plantar pad has many names. Plantar pad, plantar plate, glenoid pad, glenoid plate, flexor pad, flexor plate. It will be, all the different terms are used on my boards. It's depending how it's taught in other schools and what questions are submitted. So remember, it comes by many names, and remember what it means, okay? So when they refer to as the glenoid pad, flexor pad, it's the plantar plate. High yield, they love to ask questions about it. More or less, it's this little pad on the bottom of the joint in the, you could have it also in the plantarly in the interphalangeal joint, but we like to discuss as far as stabilization of the metatarsophalangeal joint. Plantar plate, glenoid pad, flexor pad, all of these are the same thing. They play a very important role in stabilization of the metatarsophalangeal joint. That's where kind of our, if that plantar plate mechanism is broken, stretched, torn, we develop hammer toes, okay? And we develop pain and issues with it. So that's why it's a very high yield topic. More or less, it just looks like a skinny, thick, smooth plantar little pad underneath the plantar capsule, but it plays a very important role, okay? Here's a bunch of stuff that, are surrounded by, but what's the important thing of it is that it helps to stabilize the metatarsophalangeal joint, okay? And when this pad is torn, that's when the forces become out of balance, and then things start to, you learn from Dr. Jules in Pod Surge 1, the formation of the hammer toes as a result, okay? Just understand these next two slides very carefully. This just talks about it, just understand it. Love it. Also very important to know the structures attaching to the metatarsophalangeal joint, the transverse ligament, the deep transverse metatarsal ligament, all of that. The relationships at this point become very important. So you have to understand how the tendons run in respect to the plate, in respect to the capsule, in respect to other things, okay? Flexor sheaths, collateral ligaments, all of that stuff. I just gave you good pictures so you guys could follow it. There's different types of collateral ligaments. Now, this is, again, discussing the lesser metatarsophalangeal joints. Plantar plate is also obviously present at the first metatarsophalangeal joint. Just be aware of all these little components. We could spend 2 hours reviewing them, but here they are. Deep transverse metatarsal ligament. It's very also high yield topic on the boards. Remember, it's not attached to the metatarsal head or the proximal phalanx. It's a soft tissue type of situation. So understand that it's important. We cut it in bunion surgery occasionally. So just read through it. Here's good pictures of it. Okay, first metatarsophalangeal joint. You can read on the structure. Again, here's good pictures about the components. Okay, so you're going to have some radiographs. You might have to get a picture like this, and you have to recognize, for example, this is the first metatarsal, and these are the sesamoids. So in short, when you have a normal sesamoid alignment with the metatarsal, this is the crista, they're in their respective roots for articulation. When you have a bunion, you can see that these guys are out of place and they're a little bit like irregular looking because there's arthritis that forms between them. Another board question. First, MTP joint capsule ligaments. So basically capsule ligaments of the first metatarsophalangeal joint. This joint is said to have 9 ligaments. What are they? You can ask questions many different ways, but this is basically understand. It's a high yield topic. Understand about all the surrounding structures that surround the first metatarsophalangeal joint that's supported, because you're going to have 1 or 2 questions at least, if not more, coming from that. Again, plantar glenoid, plantar plate, plantar ped. Basically, it exists at the first metatarsophalangeal joint plantarly as well. Know your flexor sheets. Collateral ligaments, know each component. They will ask about what are the components. Let's just see, deep transverse. So deep transverse metatarsal ligament, they do ask about that. Obviously, for the first metatarsal phalangeal joint situation, it's only on the lateral side, obviously. Connects the first and second metatarsal joint capsules. Remember I said this is connection that occurs at the metatarsal phalangeal joint level. Let's see, more pictures for you guys to understand. Interphalangeal joint, same thing. So basically everything's written out here. Okay, let's just run quickly through the last one. We'll finish in 5 minutes. So this is, so they said, they mentioned for ossification, okay? Identify the normal osteology, ossification, and major accessory bones of the foot on radiographs. So when this part 5 is basically, this part 5 is my lecture on ossification, right? So let's see. So here we cover ossification from tibia all the way to the phalanges. So these are the same, again, use the values that come from Dr. Dickey's handout, because that's basically what is used across the board in podiatry, anatomy, lean classes across the country. So that's the values you're gonna get. So this is for your, I mean, this is all written down. You guys could review it on your own. What I like about it is that it's one of the high yield things is that be able to identify ossification on radiographs. So I basically included in this lecture the whole ossification process of each bone and how, at what different ages, because you may be asked that on the boards. So you can go through it. So here are some examples. Okay. The one thing that they ask about is that pathologic-wise, the calcaneal apophysis, they may give you an X-ray of a 11 or 12, like 12-year-old kid, and presents with pain in the calcaneus. And the 12-year-old kid's X-ray looks like, I guess I would say, or 11-year-old 10, 11, 12, whatever. It'll look very irregular out the calcaneal apophysis. And that's just, for example, here. So you will have a kid, so the board question will be like an 11-year-old or a 10-year-old, right? They'll come in with pain in the heel, and they'll give you this X-ray and then ask you what it is. So basically, because the calcaneal apophysis doesn't fuse until 14 to 16, that's what basically you're looking at. Can it get injured sometimes and there's trauma, and it can get interrupted? Of course, but that's not what they're looking for here. This is not sports part 2 or 3. This is just understanding normal anatomy. So they're basically referring to you, trying to get you to answer about the secondary center, which starts to appear at 6 to 8. So that's referred to as Sever's disease. It's not really disease. It's a normal process. It's a misnomer in that sense. So they'll give you this X-ray of a 10-year-old, 11-year-old, and ask you what it is. And one thing to note, if they're going to give you X-rays, just without anything, just note if the growth plates are open. So then you're dealing with a kid. You know what I mean? They'll give you this and this, so you'll know it's a child. Okay. Now, os trigonum, I mentioned it before. It's when the lateral tubercle sometimes doesn't, this has a secondary ossification center and it doesn't ossify or fuse to the rest of the talus, and you get os trigonum. All right, navicular, so you guys could go through it. These are just examples. So you have example radiographs. Cuneiform, same thing. All right. So basically, I use Dr. Dickey's numbers and put them with pictures so it's easier to see. Again, challenge will be figuring out whether this is normal or pathologic, you know. But remember, look, growth plates are open, so if there's no pain, it's normal, you know, normal ossification process that's occurring in a child. Radiographs. So you're going to be able to. This is a few examples. It's very simple. You might receive a radiograph and ask what bone it is. You know, like they'll point an arrow to something and then ask what it is. It could be a bone or it could be a structure. So just know your general stuff. For example, like this guy, they could point to this and ask what it is. So that's your sustentaculum tali. Remember, on lateral x-rays, you can't tell medial or lateral, but the outline of a sustentaculum tali or an important point can be identified, okay? They could point to this, which is like, okay, this looks like the tibia, well, this looks like a fibula, things like that. They could ask about this. They like to ask about the cuneiform. You can't tell whether this is middle, intermediate, or medial cuneiform. They're all like together, but you could say it's a cuneiform. That's why we take different views on x-rays. Or they could point to this. Or this one, for example, this is like sometimes unclear, but look, this is the calcaneus, and this is the cuboid. So they could just point and ask. Same thing, they could give you an ankle view and ask what it is. Same thing here. Some examples. Another thing they asked about cleaning a spread of infection within between the compartments. So compartments was a soft tissue. You know, look in your notes about whoever covered the compartments of the foot. What's important about it is understanding. They will ask about compartments of the foot. I just wanted to point it out to you so you know. They won't ask you about compartments of the foot, the major compartments of the foot. Why? Because they'll say if the diabetic patient walked and stepped on the nail at this part of the foot, what compartment is likely infected, that type of thing. Or, you know, each compartment in the foot is related to a compartment in the leg. So the diabetic patient stepped in this area of the foot. How is the infection traveling to the leg? By what route? Depending on the compartment. So, you know, whoever you reviewed this with, you have to just understand these things because that's how infections travel up. I just didn't want you to miss it. Anatomical ankle sprains we talked about, which, you know, first, the weakest is ATFL, then the CFL, and the strongest is PTF, okay? You can read about it here. Okay, accessory bones and ossicles. This is from your McMahon's. This is a picture, but basically I included the back of Dr. Dickey's, osteology. I just pointed out the sesamoid bones. Remember, the difference between sesamoid bones is that accessory bones may or may not occur. Sesamoid bones sesamoids of the first metatarsophalangeal joint are constant. The other ones may not be, but they do occur, but understand the difference. Okay. Let's see. We're almost done. Okay, so here's some accessory bones for you to know. And it's simple. They could give you an x-ray and you just have to figure out what, accessory bone or sesamoid they're talking about. All right, here's more accessory bones, and I think we're done. Okay, so we're done with pretty much the review. Sorry I had to fly by it, but I just wanted you to be aware of kind of what things they are looking for. I will post here the actual just separate list of things, like the actual list of the together, so you can go over it on your own, but I try to answer them. Just remember, look through your previous notes and just review the neutral triangle of calcaneus, talar torsion, talar vascularizations, the Thales process, metatarsal stress fractures. They also want to understand about fusion of the middle and distal phalange, that it does occur very often, and that's pretty much it. Everything else is covered in these reviews. Go ahead. Any questions? You guys are live?
Thank you, Dr. Block. Thank you.
Thank
Dr.
you.
Block. Thank you.
Okay, do I have to end recording?
Here, where you have these three little dots and you're going to hit the recording. So go to, yeah.
Oh,
stop.
okay, got it.
Uh-huh.
All right, and if you guys have questions, if you truly are concerned about a topic you don't get, just email me and I could do like a 10-minute FaceTime with you. I don't mind helping, you know? It just has to be around the time, but we'll do that, okay?
Hey, stop recording.